We are live.
Hello, are we live now?
Okay, we are live. We are live.
Right. So, welcome everyone to the iFocus online lecture. This is lecture 410 in the cataract module on the topic of cataract surgery in uveitis and complicated cataract. I would like to welcome our moderator for the session, Dr. Varun Malhotra sir. He's done his MBBS from BYL Nair Hospital in Mumbai and PG from JJM Devangere. His fellowship in cornea and anterior segment from Shankar Nethralaya, Chennai. He is currently a senior consultant and clinical head of cornea, cataract and refractive services at Center for Sight, Banjara Hills, Hyderabad Center. He is also the course director of Eye Opener CME series for PG ophthalmology students. He is research invigilator project on tear film analysis, Department of Clinical Sciences, University of Hyderabad. He's had multiple publications and numerous presentations and awards in prestigious national and international journals and conferences. He is also credited with conducting various training programs on intact phacoemulsification, LASIK, catalyst, contact lens education, keratoplasty, etc. Over to you, sir.
Thank you so much, Garbita, for such an extended introduction. So I would now like to introduce to you today Dr. Abhilasha Baharani, who is the speaker. So I am extremely fortunate to have been known Abhilasha for the last 7 years, and I am working with her in Hyderabad. So Abhilasha did her basic medical education from Bangalore. She is a DNB postgraduate from Arvind Eye Hospital. She did her fellowship in ocular inflammation and uveitis from Arvind Eye Hospital, Madurai, and then followed it up with an international surgeon as well in Ireland. She is right now the clinical head of anterior segment at Neoretina, which is a subsidiary of Center for Sight in Hyderabad, and also the editor-in-chief of the USI newsletter. So welcome, Abhilasha, and we are very fortunate to have you today, and it will be a pleasure to listen to you. I also would like to welcome Dr. Amit Mehtani with us today. Sir has done his initial education from Bangalore, then did his post-graduation from Surat, and is currently holding a teaching position in DDU Hospital in Delhi, and many postgraduate students have been fortunate to have been training under him. So I welcome all of you today and look forward to a great lecture from Abhilasha.
At the outset, I'd like to thank Dr. Santosh, Dr. Ritika, Dr. Tulika for this kind opportunity to present my talk on cataract surgery in uveitic eyes. I thank Dr. Varun for the kind introduction, and good evening all. So I hope my slides are visible.
Yes, they are visible.
Yeah. So without much delay, I'll go on to the overview of cataract surgery in uveitic eyes. So this is the most common surgical indication in uveitis. It accounts for about 40% of visual loss in uveitis patients. Uveitic cataracts constitute about 1.2% of all cataract surgeries. About 60 to 80% eyes achieve a best corrected visual acuity of better than 20/40. However, this also depends on the type of uveitis. Like Fuchs uveitis, the prognosis is very good. Whereas in cases of JIA, juvenile idiopathic arthritis, the prognosis is slightly poorer. The post-operative best corrected visual acuity is 1 to 2 lines worse than non-uveitic eyes. So what is the pathophysiology of a uveitic cataract? As we all know, that the crystalline lens is avascular and it derives its nutrition from the intraocular fluids. So when there is deranged metabolism due to uveitis or due to intake of steroids, there is diffusion of toxins through the posterior capsule, which lacks the epithelial support. And that's how we get posterior subcapsular cataract most commonly in uveitis patients. So in this talk, I will cover preoperative assessment and preparation, intraoperative challenges and techniques, and postoperative complications and management. Coming to preoperative preparation and risk assessment. So it is very important for us before we undertake any surgery to assess the risk in the patient. So very often, this is the clinical picture that we see in cases of uveitic cataracts. So when there is no view of fundus, you can still assess the level of inflammation by doing an ultrasound B scan. If the vitreous cavity is clear, make every attempt to look at the choroidal thickness. Even if there is no vitritis, a thickened choroid indicates an active case of uveitis. Coming to assessment of visual potential, wherever possible, if the fundus view is clear, always assess the visual function, look at the optic nerve. This is a case of multifocal choroiditis with optic neuropathy. Now here you see after healing, if you see the right eye optic disc and the left eye optic disc, there is a slight temporal pallor in the left optic disc. Now in this patient, that pallor has led to a centrocecal scotoma on visual field. So now you can give the prognosis to the patient. So it's very important to assess the visual potential, look at the optic nerve, and if possible, get a visual field done and inform the patient that there is a scotoma in your visual field which will persist after cataract surgery. Now, this is another case, sorry. This is another case of sarcoid uveitis, where you see that you can see the snowballs here. Now, while we are busy assessing the snowballs, we might miss the optic nerve head. Okay, so as uveitis specialists, we are very busy looking at the inflammation, looking at the vitritis, and we might miss the optic disc. And when you see carefully, my slide is not moving. Yeah. So now if you see the optic nerve head, you can see that this patient has a clear-cut case of glaucoma, and this inferior nerve fiber layer defect corresponds to the visual field defect superiorly. So again, it is very important to look at the optic nerve, also check the pupillary response and color perception wherever possible. Coming to macula, many a time after treatment of uveitis, there might be a macular scar or a CME. Now, cystoid macular edema is a very vision-threatening complication of uveitis. And before planning cataract surgery, always get an OCT done. You can see an ERM. And sometimes this is a case of dense cataract, and when we did an OCT, we saw a full thickness macular hole. So before planning cataract surgery in any case of uveitis, always get an OCT done. Coming to risk factors for postoperative hypotony. Hypotony, as we all know, is more difficult to manage than increased intraocular pressure. So if intraocular pressure is less than 6 millimeters of mercury, even when the eye is quiescent, or we see a normal intraocular pressure, even in the presence of seclusion pupil, we should do a UBM, that is ultrasound biomicroscopy, and look for ciliary body traction. And these are often seen in cases with juvenile idiopathic arthritis. And whenever you see these traction bands, always plan a pars planar lensectomy along with vitrectomy. These patients should be dealt differently than other cases of uveitic cataract. Also, poorly controlled inflammation is a very high risk factor for postoperative hypotony. Coming to timing of surgery, the eye should be ideally quiet for 3 months. However, if the fundus is visible, if you are able to assess the retina, wait for as long as possible for full control of inflammation. In these patients, cataract surgery should be delayed as much as possible. However, early cataract surgery is preferable when we need to assess and manage posterior segment pathology. Often, if the cataract is very dense and you're not able to assess the posterior segment, then early cataract surgery should be done. Also, if the cataracts are very advanced, like I showed in the first slide, which pose greater surgical difficulties, even then, early cataract surgery can be planned. Coming to counseling, the counseling for uveitic cataracts is very different from senile cataracts because the patients need to be informed about the visual prognosis and that the surgery may take longer than usual. Often we need to do extra procedures like pupil expansion, and this has to be informed to the patient. Also, there is a possibility of delayed visual recovery because these patients need prolonged post-operative steroids, and often the visual recovery is delayed. Many times patients think that once cataract surgery is done, they need not take their systemic medication. So before cataract surgery, this has to be informed to the patient that whatever systemic treatment they've been put on will have to continue that even after cataract surgery, and they need to come for frequent follow-up. Now, these patients are often young. They do not have senile cataract. They have these complicated cataracts, and they need to be informed that they'll need reading glasses post-surgery. Sometimes that comes as a surprise to these patients. Coming to preoperative preparation. Now, whenever we see a case of uveitis, uveitis is a common phenotype of many systemic diseases. About 83% of uveitis patients have an associated systemic disease. So, if you see cells and flare and you diagnose uveitis, that is just a general diagnosis. A specific diagnosis needs to be made, which will guide the preoperative control of inflammation. So before planning cataract surgery, make every attempt to make an etiological diagnosis of uveitis, and absolute and long-lasting control of ocular and systemic inflammation predisposes uveitis patients to satisfy. You can get good results only if you have very good preoperative control of systemic as well as ocular inflammation. iFocus has a very good uveitis module as well. Coming to steroid prophylaxis is recommended, especially in those cases of macular edema or recurrence, or where the patient is predisposed to hypotony, as in cases of VKH. Now, nowadays we have very advanced systemic immunomodulated therapy, and it is most of the patients do not need steroid prophylaxis these days. In my practice, there are no strict guidelines, but in my practice, I step up the systemic immunosuppression 1 month prior to surgery. Wherever you are comfortable and you want to give oral steroids when there are no systemic risk factors like diabetes, oral steroids can be started 1 milligram per kg body weight, starting 3 days preoperatively, and they should be tapered to preoperative levels in 1 month. Where there are systemic risk factors or when the patient has unilateral non-infectious, you can also plan local steroids like intravitreal triamcinolone or posterior subtenon triamcinolone or intravitreal dexamethasone. These local steroids do not have any systemic adverse events. However, they should be best avoided in the absence of an etiological diagnosis. If there is any suspicion of infectious uveitis, local steroids should be avoided at any cost. Coming to prophylaxis for infectious uveitis with a propensity to reactivate, like toxoplasmosis and herpetic uveitis. If you have made a diagnosis of these conditions, you have to give prophylactic treatment. Now, choice of surgery, phacoemulsification is the obvious choice because it causes less inflammation. So wherever possible, phacoemulsification should be planned. When there is coexistent cataract and glaucoma, cataract should be done first, followed by glaucoma surgery. This is because if you do a combined surgery, inflammation due to cataract might fail the glaucoma bleb. So in these cases, we have to plan a sequential surgery. When there is cataract and coexistent retinal problems like an ERM, a combined surgery can be planned. Anesthesia is surgeon's choice. So the options are peribulbar, and subtenon anesthesia. These cases cannot be operated under topical anesthesia because there is a lot of tissue handling and you might need to handle the iris and dilate the pupil. So topical surgery cannot be done. So subtenon anesthesia is a painless procedure basically, and you just need a 23 gauge single port cannula and peribulbar anesthesia. So this is a video that shows the procedure for subtenon anesthesia. You just enter the subtenon space and with the single port cannula, you can inject the lignocaine bupivacaine combination. So coming to intraoperative challenges and techniques. So the surgical challenges that we face are small pupil, shallow AC, posterior synechiae, peripheral anterior synechiae, pupillary membranes, and zonular lysis. My slide is not moving. Just a second. So I'll show. Yeah. So I'll show two eyes of the same patient. Now, in the first eye, I have used iris hooks for pupil dilation. So I'm releasing the posterior synechiae. Now, when you are making side ports for the iris hooks, you have to go directly towards the pupil margin. You need not make a long tunnel. Placement of iris hooks is very straightforward, but it should be done in a sequential manner. Do not tighten all of a sudden. That causes large sphincter tears. So what I'm using is a diamond configuration. So the advantage of using a diamond configuration is that your instruments do not touch the tented iris. Now removing the iris hooks is also very straightforward. You just need to pull it out. Here, if you see in a square configuration, the iris is tented when you enter with a phaco probe, but that does not happen with a diamond configuration. Here, if you see, I have cleaned the viscoelastic from behind the IOL as well, because viscoelastic also causes significant inflammation in these eyes. Now, I'll show a video of complications of iris hooks. So this video is courtesy of Dr. Arup Chakrabarti. Here, if you see, the iris hooks all are tightened all at once, and then there is mushrooming of fluid in a case of intumescent cataract. Now here again in a square configuration, the chopper had touched the tented iris, and now there is bleeding. So now there is continuous bleeding from the iris. And the entire surgery becomes difficult. So these eyes need very meticulous handling. Now here there's another complication where the iris tissue is pulled along with the iris hook. So the surgeon has to be very careful while performing surgery in these eyes. Coming to the second eye of the same patient, where I have used a BHEX ring for pupil dilation. Now again, the surgery is being done under subtenon block. And here, when you are using a BHEX ring, you have to do a stretch pupilloplasty, inject viscoelastic over and under the iris. This was my first case of BHEX ring. So it has got 3 flanges and 3 holes where you have to engage the iris, and removal is also straightforward. Again, cleaning the viscoelastic from behind the IOL. So now comparing iris hooks and BHEX ring as pupil expanders. So pupil size and shape, the pupil size is almost the same, but pupil shape is better in BHEX ring, especially when you're trying to make a large round capsular rhexis. There's a slight learning curve with BHEX ring. Putting hooks is very straightforward. Surgical maneuvers are easy with BHEX ring because there is not that much shallowing of the anterior chamber compared to the iris hooks. The surgical time is shorter with BHEX ring. However, post-operative pupil's shape is smaller. It is better with the BHEX ring, but post-operative astigmatism is comparable between the two. Now, there's one more question that is often asked, whether do a PI or we should not do a PI in a case of uveitic cataract. So, clear corneal phaco with a large continuous curvilinear capsular rhexis without surgical PI is the preferred technique. However, you can get posterior synechiate to capsule if you make a small rhexis. So, if you make a large rhexis, a PI is not needed. In pediatric uveitic cataracts, PI definitely helps because these eyes are at very high risk of postoperative glaucoma. Coming to the type of intraocular lens, so in a large Cochrane database systematic review, it was found that acrylic intraocular lenses or heparin surface modified PMMA IOLs result in better visual outcome and lower postoperative complications than silicone or unmodified PMMA IOLs. Here I'd like to add that hydrophilic acrylic IOLs have been proven to be more compatible to uveitic eyes compared to hydrophobic acrylic IOLs. However, hydrophobic IOLs are preferred because they lead to less incidence of posterior capsular opacification. Also, multifocals are best avoided in these cases. Even in cases of Fuchs uveitis, it is patients do have floaters and the floaters are persistent. So multifocals should not be used in these eyes. Now coming to another question, intraocular lens or no intraocular lens in pediatric eyes. Now, postoperative aphakia is associated with better long-term visual prognosis in younger children who are lesser than 5 years of age. This is because when you put an intraocular lens in a very young child, there is very high chance of high postoperative inflammation and recurrences, which leads to failure of the surgery. The lens can always be implanted at a later date in very young children. However, heparin surface modified PMMA IOLs or acrylic IOLs in fully controlled inflammation for at least 3 months, intraocular lens is not a formal contraindication. According to one study, 80% eyes achieved visual acuity of better than 6 by 9.5 when uveitis was in control for at least 6 months prior to surgery. The common complications are posterior capsular opacification, glaucoma, and cystoid macular edema. Now coming to postoperative complications and their management. So postoperative inflammation can be controlled with aggressive topical, oral, and periocular steroids. Always prescribe a non-steroidal anti-inflammatory eye drop in these eyes. To avoid posterior synechiae and pupillary membranes, keep the pupil mobile. You can use homatropine twice a day for at least 1 week, and you can avoid such circumstances. So the principle is to overtreat and relax, and don't undertreat and then try to catch up. Now, coming to posterior capsular opacification and capsular phimosis, this is the most common complication following cataract surgery in uveitic eyes. You can also see cocooning of the lens. So there is posterior as well as anterior capsular membrane. And here you see a case of capsular phimosis. So it can be prevented by making a circular, large, well-centered capsulorhexis. Hydrophobic acrylic IOL, as I have said before, with square edge design is better than hydrophilic IOLs in preventing PCO. There should be meticulous removal of viscoelastic from within the bag. It is always recommended to go behind the IOL also and remove the viscoelastic, because retained visco can always cause more inflammation, and postoperative inflammation should be controlled very aggressively in these eyes. Coming to postoperative cystoid macular edema. Now, this is the most vision-threatening complication in uveitic cataract eyes. So the incidence of CME in uveitis with well-controlled inflammation for more than 3 months is comparable to non-uveitic eyes. The risk of cystoid macular edema is about 6.7-fold higher in eyes with a history of previous CME than those with no history of CME. And cystoid macular edema is, as expectedly, more common in Behçet's uveitis than in other etiologies. And the mean period until development of cystoid macular edema is about 7 months. So once there is a CME, this can be controlled with local steroids. And the risk of CME can be reduced by using postoperative non-steroidal anti-inflammatory drugs. So to summarize, etiological diagnosis of uveitis is important for well-controlled inflammation. The timing of the surgery should be appropriate. Patient has to be counseled regarding the visual prognosis. Intraoperative challenges can be avoided by well-planned and meticulous surgery. Postoperative care and management of complications lead to good visual results. Thank you.
Very nicely presented by Dr. Abhilasha, and where she has elucidated the fact that all the uveitic cataracts have to be diagnosed etiologically, because different etiologies may have different visual prognosis. A visual potential assessment preoperatively by means of various modalities that are available to us, whether it is a B scan in a visually an opaque media, or the presence of the use of a UBM for diagnosis of a cyclitic membrane, or the use of an OCT or an angiography or a specular microscopy sometimes, because such patients, because of the persistent inflammation, may have a low endothelial count, and a potential acuity assessment, a visual assessment, a potential acuity meter or a macular function test prior to the surgery is very important. Also, control of inflammation is paramount in these cases, because the post-operative inflammation is and the pre-operative control is important, and the intraoperative measures that we need to take during the surgeries. Thank you, Dr. Abhilasha. Now we can discuss a few important points, ma'am. What is your preferred approach when you have a patient who has a posterior synechiae as well as a peripheral anterior synechiae coexistent in a particular cataract case? How would you go around removing the peripheral anterior synechiaes or the posterior synechiaes? How do you do that?
Yes, sir. So thank you for that very important question. Sir, peripheral anterior synechiae, they do pose a challenge in the sense that they can, if the patient has peripheral anterior synechiae, I generally plan a PI in these eyes. And it is not easy to remove the peripheral anterior synechiae. Even if you go with a viscoelastic and you remove it during surgery, after surgery, again, the iris goes and sticks there. So in these eyes, it is not exactly possible to make them free of peripheral anterior synechiae. But even then, during surgery, I would take a visco cannula and try to release the peripheral synechiae as much as possible. With posterior synechiae, what I do, the steps of surgery, I go with the MBR blade, and before even I inject the viscoelastic, before injecting the trypan blue, I take the iris spatula and I remove the posterior synechiae. I release the posterior synechiae so that when we inject the trypan blue, you can stain the capsule as much as possible.
That is prior to the use
So
of.
at least on one side, if you're able to. So even on one side, just as you enter with the MBR blade, even on one side, if you're able to release the posterior synechiae, I showed it in the video also, that one side I was able to remove the posterior synechiae. On the other side, I can do it even after putting the viscoelastic. So if you remove the posterior synechiae before staining the capsule with trypan blue, you will be able to stain more of the capsule.
That's
So
that's a
that
very
is
important clinical pearl, because staining of the capsule is very important in such cases, because the visibility is not very good. Also, ma'am, would you like to share your pre-operative protocol for steroids in such cases? How do you use them? How do
yes.
you taper them?
Yes. So I'll that's again a very good question. So I will divide my steroid protocols into systemic as well as local. So in my cases, I prefer to use systemic immunosuppression. It is very rare that I use systemic steroids in patients. Now, systemic steroids I mostly use in cases of aggressive uveitis. There are certain etiologies very aggressive, like BKH disease. We need to start them on systemic steroids because the post-operative course is very aggressive. So I start the patient on 1 milligram per kg 3 days before the cataract surgery. Okay, so and if the patient weighs more than 60 kgs, I do not put them on 70 or 80 milligram steroid, because that if you put them on very high doses, they have a very high chance of getting avascular necrosis of the hip. So it is not recommended to go at very high doses. In these patients, we can also give local steroids when we are sure that it is a non-infectious uveitis. I never combine the local steroid along with cataract surgery, because if you get post-operative inflammation, you will find it very difficult to differentiate whether it is an end-off or it is a reactivation of uveitis. So in these eyes, my preferred local steroid is intravitreal dexamethasone, because it is long-acting. And if you are using dexamethasone, better to give it 3 weeks prior to surgery, so that it can have its effect when you do the surgery. So by the time you plan the surgery after 3 weeks, the inflammation would be very well under control. If you are planning a triamcinolone, you can do it just 3 days before surgery, either intravitreal or posterior subtenon. If the patient is not affordable for intravitreal dexamethasone, you can plan triamcinolone steroid.
Thank you so much. And what are your preferred immunosuppressive agents as per the etiology of the uveitis?
So if you see patients with HLA-B27 uveitis, now these respond very well to methotrexate, and these eyes are like, we know, like I don't plan cataract surgery like first time when I see a patient with uveitis and cataract. So I try to delay the surgery as much as possible and try to control the inflammation as much as possible. So if a patient of HLA-B27 comes to me and with a posterior subcapsular cataract and the vision is 6/9, so I will control the inflammation with methotrexate, and depending on his blood counts, we know, and the CRP levels, we know when the inflammation is under control and at what dose. Now, when this patient's vision drops to say 6/12 or 6/18, then I plan surgery. And when I plan surgery, 1 month prior to that, I'll step up the methotrexate by 2.5 milligram per week. Okay. Another case, like in a case of VKH, I said preoperatively I'll start them on steroids. There are other cases of, say, Behçet's. Now, Behçet's patients are always on systemic immunosuppression. And again, in these eyes, I step up the drug, and the preferred drug is the preferred combination is azathioprine as well as cyclosporin. So in these patients, I step up 1 month prior to surgery. So different, So different etiologies have different preferred drugs. Then we have mycophenolate. Mycophenolate is very good for sarcoidosis. So if you have a case of sarcoidosis and the patient is on, say, 2 gram per day of mycophenolate, you can increase it by 500 milligram 1 month prior to surgery. And generally, I continue it to up to 6 months post-operatively, because as we know from studies that patients get the CME, post-op CME, generally 6 to 7 months post-operatively.
Any specific indications, like suppose you have a patient who has a CME pre-existing because of the uveitis, and we need to actually, it's a visually significant cataract and we need to deal with it. So would you prefer giving Ozurdex 3 weeks prior to the surgery, or what would be your preferred modality in such a case, ma'am?
Yes, so if you are able to see the CME, that means we can wait for 3 to 4 weeks at least, because we are able to see the CME. That means the fundus is still clear. Now, so if we have an etiological diagnosis, patient is already on systemic treatment, my preferred mode is intravitreal dexamethasone for CME. But sometimes patients may not be very affordable. In such cases, we can give posterior subtenon triamcinolone, and that can be given even 1 week before surgery.
What about intravitreal triamcinolones? Intravitreal injections of triamcinolone?
I generally don't prefer intravitreal,
Right.
because it causes that white blob. I don't generally prefer using intravitreal triamcinolone.
Right, ma'am. Very nicely presented, ma'am. Dr. Varun, your inputs?
Yeah, Gavita, do we have any questions from the postgraduates?
We don't have any questions in the chat box and neither on YouTube, sir. No questions till now.
So my query to Abhilasha would be that since you operate a lot of uveitic cataracts, what would you use as a pupil expander? Generally, I mean, what's your preference? For most of these cataracts would be having posterior myopia.
see, there are some
I think Abhilasha's connection is not clear. No?
which are very small. Now, for BHEX ring, you need maybe I can stop the video and try.
Probably. I think it's just go ahead, Abhilasha, please.
Yeah. So, yeah. So thank you for that question. See, sometimes for the BHEX ring, the pupil has to be like slightly bigger. If it is like a very small, a pinpoint pupil, it won't get expanded with a BHEX ring. So in such cases, I prefer using hooks. Because you need to like really pull the you really need to pull the pupil over to get a good view. Where you don't have 360-degree synechiae. In these cases, I prefer BHEX ring. So when you don't have 360-degree synechiae, it is easier to expand with the BHEX ring.
Have you ever used Malukian rings, Abhilasha, in uveitic cataracts?
No, I don't use Malukian ring because of the cost, and yeah, I haven't used it much.
Another thing which I would like to put to Abhilasha is, what is your experience? Because generally these are patients who have some amount of underlying inflammation always. Have you come across membrane formation retro-IOL, in uveitic cataracts, and what do you do? Do you suggest membranectomy from the posterior route immediately, or you wait for some time? How do you want to manage these patients?
Yeah, you see, in these cases where you have these ciliary body traction bands, I always see the patient has 360-degree synechiae or occlusio, cyclosio pupil, and the intraocular pressure is still normal. Patient does not have glaucoma. That means that these patients, there is some ciliary body shutdown because of fibrosis or traction. And in our center, I do the UBM. And if I see traction bands, then I plan generally pars-plana lensectomy and vitrectomy. I do not attempt phaco in these eyes because this happens generally in younger patients, in small kids with JIA.
And you leave them aphakic, or you try to do a scleral fixation?
Yes, it is better to leave them. Yeah, it is better to leave them because these patients had very severe inflammation. It's better to leave them aphakic if they are less than 5 years of age, and then plan cataract surgery at a later date.
Are there any indications, Abhilasha, where you would, I think you have already mentioned in your presentation that the PIs are very far and few now, but are there any specific indications where you would want to do a surgical PI along with the cataract?
Mostly I do it in younger patients like kids. Because they have a very high chance of getting glaucoma later. There are no known reasons, and I have searched the literature on this, that why children get glaucoma post uveitic cataract surgery. There are no clear reasons why it happens, but in children, I always do a PI, not only one, I do 2 PIs always.
Okay. Okay, and another thing, Abhilasha, you clearly mentioned that you do not obviously attempt multifocals in uveitic cataracts. I think it's fair, but do you have any experience with EDOF lenses like Vivity? Do you use them in uveitic cataracts, and what has been your
No,
experience?
I try to avoid all such lenses which will use the contrast by even a very small percentage, because these are already compromised eyes. And if you see like patients with Behçet's uveitis, all of them have optic nerve disease. Most of them have optic nerve disease, and then I try to use only simple monofocal lenses in these eyes, so that they get at least the best contrast possible.
And uveitic cataracts, do you generally give oral steroids as a post-op care, Abhilasha?
If I've started or if I've given preoperative prophylaxis, I will definitely, I'll continue till, and I'll do a very slow taper, maybe 5 milligram per week post-operatively. But if I have started preoperatively, I mean, if I haven't felt the need, started post-operatively. It is very late, So if you have to plan steroids, yeah, it has to be planned pre-operatively.
I think that's about it. I think Dr. Amit, do you want to ask anything?
Yeah, another important subset is where you have a coexistent glaucoma, which is fairly advanced glaucoma, and you want to tackle both the situations surgically. So, what is your preferred modality? Whether you would go for an anti-glaucoma surgery followed by cataract surgery, or you would like to do simultaneously do a combined phacoemulsification with the trap?
Yes, sir. This is a very common scenario where there is glaucoma and cataract. So in these eyes, first cataract surgery should be done, because if you do a combined cataract and glaucoma, there will be some amount of post-operative inflammation in the anterior chamber, which will cause a failure of the bleb. So always better to do cataract, and maybe 2 months, 1 or 2 months later, you can do the glaucoma surgery.
Perfect. That's how it should be.
I mean, have you also done cataracts with the tubes in such cases, in uveitic cataract, as a single procedure?
Tubes actually, even though we know that trabeculectomies do fail in uveitic eyes, and try to see how long the trap can control the IOP, and then probably go to tube, because tube is the last resort. So if you start with the tube and the tube fails, then you don't have any hand.
But
So
generally,
better to do
Abhilasha,
trabeculectomy.
I'm sorry, but don't you feel that there's a very high probability of the traps failing in uveitic eyes? Because
No, those like if you see nowadays, we have a lot of options to control the like if you see, even when we were studying in 2006 and 10, those days we did not have so many options for local steroids and so many systemic immunosuppressive drugs. But now we have a lot of options to control the inflammation, and I have seen that patients with the trap does survive. If the inflammation is well controlled, the trap does survive, and it should be given a chance to, control the intraocular pressure. Because if you straight away put the tube, and if the tube fails for any reason, the surgery was not done properly, or the scleral graft, there is some problem with the graft, and if there is a failure of the tube, then you don't have anything else to fall back to. So I think trap should be tried first, and then see. Sometimes I have patients who are still surviving on trap for the past 6 years, 7 years. So we can try that option first.
I have one question from YouTube. So the question is,
Yes.
what is the role of subtenon triamcinolone post-operatively?
See, thank you for the question. Post-operatively, if the patient has got a cystoid macular edema, and you are not able to control it with topical NSAIDs, then posterior subtenon triamcinolone is a good option to control the CME, to treat the CME.
Any other questions, Dr. Amit?
Another subset that I would like to stress upon is the herpetic keratouveitic patients. Uh, we are starting them on a prophylaxis for antiviral therapy. Do you want to continue this post-operatively? And how long?
Yes, for 1 month. For
Post-op.
1 month post-operatively, yes.
And also, I would like to say that sometimes you have a patient who has a sclerokeratouveitis. So, what would be your preferred choice of surgery in such patients? Would you like to go for a clear corneal incision, or would you like to modify the incisions accordingly somehow?
So when the patient has got sclerokeratouveitis, you have to choose the site of the clear corneal. I would still prefer clear corneal phacoemulsification, but you have to be away from the site of corneal inflammation. So wherever you see, even if the patient has got temporal, then you have to sit superior. If patient is superior, then try to sit temporal. So try to avoid the area of inflammation. And wherever there was the initial involvement in the sclera or the cornea, and these patients, the inflammation has to be controlled like really well before you plan surgery, because sometimes they can even land up in necrotizing scleritis post-operatively.
I think just to add to what Abhilasha said, I think, sir, it would, in these cases, it is, to be honest, maybe counterproductive to do a scleral incision in sclerokeratouveitis. It's still better to do corneal incisions at a different site and avoid where you have some amount of scleral thinning. Also, to answer to what sir said, sir, because I'm a corneal surgeon, even when I do PK or post corneal opacity following an HSV keratitis, we would definitely start oral acyclovir, a month prior to the surgery and continued 1 month post the surgery. I think that would be quite a norm. The antiviral prophylaxis for any surgery, frankly, a month prior, 1 month pre-op and to continued 1 month post-op to give it a good coverage for it.
Absolutely, absolutely.
So I think, Gavita, do we have any more questions?
No, sir. No more questions.
And Dr. Amit, sir, do you want to ask anything or you're done, sir?
Absolutely. We had a very comprehensive discussion on a topic which has a lot of permutations and combinations attached to it. And it was a pleasure listening to Dr. Abhilasha, and it was a very nice talk.
Thank
So
you.
I think with that, Abhilasha, if I have any more questions, I'll call you or I'll just come over to Neoretina to ask you personally. I can just drive down to meet her. Anyways, that was thank you, Abhilasha, for this comprehensive lecture. I think it's definitely very beneficial for all the postgraduates. It's a very important topic. I obviously learned quite a lot and look forward to many more of these lectures. So I think good night to all of you and thank you for taking out time on a Friday evening to teach the postgraduate students.
Thank you. It's always a pleasure to be on iFocus.
Yeah. So bye.